Hi, this is Roger Green, host of the Surfing the MASH Tsunami podcast. This week, we are offering 5 conversations from episode 23, our discussion on challenges in physician-patient communication stemming from a session at the EASL Congress, with Louise Campbell, session co-chairs Shira, Zelber-Sagi, and Mike Betel, and panelists José, Willemse, and Tom Marjot. Plus, from the vault, a discussion from Shira's previous appearance on Surfing MASH in the U.S. Thanksgiving 2022 special. This episode's a bit unusual for 2 reasons. First, I'm not part of the conversation. Louise leads it brilliantly in my absence. Second, it focuses far more on the patient and the role of the physician-patient interaction in steering treatment. I found this fascinating and hope you do as well. This conversation focuses largely on the role psychosocial and socioeconomic needs play in both Masled and the related physician-patient dialogue. It starts with Shira asking Tom whether he addresses diet with his patients and, more important, whether he does so in the context of socioeconomic challenges such as not recommending food that is too expensive for the patient. Tom says yes to the first part about diet and nutrition discussions and encouraging all patients to adopt a more healthy lifestyle, but he says he's not sure he does enough on socioeconomic issues. He feels this may be changing, though, based on the increasing discussion of food insecurity at conferences and other events. The two agree that sensitivity on this topic is growing and needs to grow more in the years ahead. And also, that while they are tailoring their discussions to address these issues, they can do more. Shira has begun to simplify her recommendations: fewer foods, less preparation time. Tom agrees this is a good idea. Tom also notes that he is spending more time these days focusing on unemployment, social isolation, and what he describes as social unmet needs. He cites figures that 80% of the patients in a liver clinic have unmet needs in this regard, and that improving social engagement can affect health. Mike asks whether the providers consider mental health, particularly given how important behavioral support is to treatment. Do Tom or Shira recognize mental struggle when the patient is sitting in front of them? Tom says this is an excellent question and identifies the 3 items that patients in large studies say they seek from physicians on this area: education, reduction of stigma, and better psychosocial support. Mental health challenges are linked to unmet needs, which again are linked to poor liver health. Tom believes the UK system does a good job in identifying this issue at the primary care level. Shira agrees this is important and, in her case, involves using quiet, probing questions in a sympathetic tone. As the conversation winds down, Louise asks whether Tom or Michael have observed Masled-specific patient support groups in their regions. Both report that there are liver support groups, but nothing yet as specific as Masled. This carries over into the next conversation. As I noted at the beginning of this introduction, this episode has a few things that make it really different. Focus on patients, me not being a part of it, and a really engaged panel that has diverse backgrounds. Conversation moves fast, covers a broad range of issues, so just sit back, listen, learn, absorb, and when you're done, join the conversation in our LinkedIn discussion group.
Shira, Zelber-Sagi.
I have a question to Tom about it. Tom, we live in a toxic, obesogenic environment, and we tell the patients to eat healthy food, which is also more expensive. Do you get to discuss it with patients? Do you get to discuss the issue of the environment and how they can manage their eating in this environment, and also about socioeconomic factors like some of the foods? Because some of my patients tell me, what you recommend is too expensive for me. I get to hear that a lot.
Tom Marjot.
Yeah, that's a really good point. So, the first part of your question is, yes, we're addressing diet quite rigorously, and we're explaining about the environmental factors driving their liver disease. And we also, listening to your conversation, we always emphasize it's never too late for these changes as well. Some patients think, they've got advanced liver disease, or, they're this age, or they've had this disease for so long. But actually, it's important to emphasize to these patients it's never too late to implement these healthy lifestyles. And so diet, we do tackle quite robustly. But the second part of your question about socioeconomic status and expensive foods, I don't think we tackle enough. But I am noticing a lot of conferences at the moment, food insecurity is becoming much more topical. There's a lot more talks and a lot more research emphasis on understanding the socioeconomic drivers of poor diet and how we can deliver healthy diets in a way that isn't too expensive. But actually, I think it's lagging behind. I think the field has been very focused on establishing what's healthy and what's not and delivering that message. And actually, probably in the years ahead, we need to be much more nuanced about how we tailor that dietary advice according to the patient's phenotype, but also according to the patient's socioeconomic status. Are you managing to do that, Shira, in your practice? Are you taking account of these socioeconomic factors?
Yeah, actually, I got more sensitive to this topic than I was in the past. I've always heard from patients that some of the foods that I recommend, like fish and walnuts and olive oil, are too expensive for them. So it's nothing new. But I think in the past year, years, it became worse, and I get more sensitive to this topic of food insecurity and socioeconomic inequities. And then I try to think with a patient what kind of diet we can tailor that would be less expensive. For example, if they reduce their sugar beverages consumption, they actually save money, right? So there's no excuse to continue having sugar beverages. But also trying to explain to them that you don't need to eat expensive food or food that takes a lot of time to cook. It can be very simple. It can be whole grain bread, low-fat cheese, some vegetables and eggs, and you have the healthiest meal, right? So you don't have to do anything too expensive or too complicated cooking. You don't have to spend hours in the kitchen to actually have a very healthy meal. So what I'm trying to do more and more is to simplify my recommendations.
Yeah, that's really helpful. I think we need to be doing this. I need to be doing this more, particularly because we know that social isolation and unemployment are big drivers, both of liver disease, but also of unmet needs. So if you look at patients in the clinic, 80% of patients have got unmet needs in the liver clinic. That's nice data showing that. But that population is enriched with those that are unemployed or socially isolated. And then if the information you're then delivering is useless to them because they can't afford the food in which you're recommending, then it just becomes a futile circle. So I think this has been that's helpful, Shira, for us to think about as clinicians going into these clinics about how we tailor our advice based on socioeconomic background.
José, Willemse.
Yeah, and what I see a lot is when you look at diets, and I've never found a diet just with the vegetables and fruit of the season, because that's always cheaper. And when I was young, we didn't have all those prepared and already cut vegetables in the shops. It was very basic food. And I discussed that with some lady on my own age, and she said, well, you're true. It doesn't exist, all those sauces and other things you can add to your food. And she skipped those things. She just thought, well, how did my mom cook? With less salt. That's true, because they used a lot of salt when I was young. And it helped her. So it's just, I think we have just go back to the basic.
Yeah. Go back to basic.
Mike Betel.
I wanted to ask Tom and Shira, and Tom had mentioned isolation. Do you recognize mental health, because behavioral support is incredibly important for treatment now? Do you recognize in a patient when you're in front of them that they may be suffering from some mental struggles?
Yeah, it's a really good point. I mean, I like looking at the big patient-reported outcomes data, actually, because I think it can feed right down into the individual consultation. So when you ask a huge group of patients, thousands and thousands of patients, what we can do better. When you ask them that question, what we can do better in clinic, they say three things. They say better education and information, which we've touched on. They say reduce public stigma, which we've touched on, but they also say better psychosocial support. And the reason is because we know that patients with psychosocial issues or mental health issues, we know they have a high burden of unmet needs. And we also know that they get bad liver disease. So I think the first thing is recognizing the data showing that it's a really big issue in our clinics. And then to come back to your point, Michael, about are we recognizing it? I think we're quite good. I think we're quite good at screening, of probing, and then of signposting to services, which is in the UK is nearly always through primary care, nearly always through the GP. And actually cultivating that relationship between the hospital doctor and the GP is pivotal in helping access to mental care support. But there is so much mental health, particularly in the alcohol-related clinics, and the Hep C clinics, but increasingly in the MASL clinic, which is probably been under-recognized. But we do try our best to signpost to services when we see it. Shira, I don't know if you agree.
No, I completely agree. I try to ask very gently. I don't want to be too invasive with the questions. So I look at the patient in the eyes and ask, how is your mood recently?
Yeah.
Or do you sleep well? How is your sleep, for example? So like a very delicate questions to see whether the patient is interested in opening this topic. Usually they are very interested to talk. They just waited for someone to ask. And it's also very much related to obesity. For example, if I see a very strange weight gain, like the weight jumps up and I realize there could be some stress related to eating, or It's less common, but also a very large weight reduction. Can also be something that has to be with a psychological state, or we start looking for other things like HCC surveillance, but that's another issue. But it's really important. I do ask the patients how they feel, how they sleep, how is their mood. Of course, it's very much related to the way they eat. There's a lot of emotional eating. So it's very much related to my work.
Louise Campbell.
So can I ask, there was a discussion in the room about engaging more with people who've got lived experience from different areas. Now, having in the past operated and run and facilitated patient groups, probably more in viral hepatitis or in psychiatry, do we have, or are people aware of muzzled patient groups within hospital settings, or are they just liver specific? If you run one, for example, Tom or Michael, is it something that's common in Canada that you get patient support groups just run in hospital for muzzles, which is now a growing population, and obviously obesity and stigma comes strongly into some of those?
Yeah, so we do have muzzle-specific support groups in the UK. Their role is very much highlighting patient needs, highlighting that there are unmet needs. But the lived experience thing, and correct me if I'm wrong as a group, but the lived experience side of things, where I've seen this best is within the viral hepatitis space, which is people that have had really tough lives, who have overcome lots of barriers, who have got treatment for their hepatitis C, and then are now becoming integrated within the care pathway for outreach and to target patients and to help recruit patients into eradication. And so they're really using patients with lived experience to actually become part of care delivery. And that's really powerful within the viral hepatitis space. But I don't think we're seeing that yet within the muzzled space.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any comments or questions about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded the conversation, or send an email to questions@surfingmash.com. It's not clear what we're going to be doing next week. We're looking at approaches featuring NITs and a separate one focusing some basic science. Either way, I'm sure it'll be fascinating, and I can't wait for us to put it out for you next week. Until then, stay safe, surf on. We'll see you on podcast. Bye-bye now.